Hi, thank you so much for being here. I'm going to give the other participants maybe a couple of minutes, maybe till 5 past the hour, just to see. Oh, someone else.
Hi.
Hello. Sorry, Kenan?
Yes, I just said hi to you.
Oh, hi. Great to meet you. So thank you guys so much for being here. I'm going to give the other participants another couple of minutes to see if anyone else shows up. So we'll plan to start at maybe 5 past the hour.
Sure.
Thank you.
Mm-hmm.
Hey guys, I know a couple people just jumped in. We're gonna plan to start in about 2 minutes. I don't know. I just got a message on my screen that said participants can now see your application. Does that mean that the meeting chat is blocking the slide, or are you guys able to see the whole slide?
I can see it fine.
Okay, perfect. Do you guys have access to the quiz and the note?
Yes, we do. We know
Perfect.
where it is. Mm-hmm.
Wonderful. Thank you so much for responding. I'm not going to be cold calling anybody during the meeting, so don't worry about that. Feel free to either message me privately in the meeting chat, or you can message the group, or you're always welcome to unmute and talk. This is for your benefit. So I'm excited to get started. So maybe we'll start a minute early. So hi, everybody. Nice to meet you. My name is Jackie. I'm a recently matched internal medicine resident, just graduating my medical school. So I'm really excited to talk to you about this topic. This is really high yield, something that comes up a lot. And you may even know some famous people in history with some of these diseases, or maybe you know someone personally. So I think this is going to be a really interesting topic. I'm happy you guys were all able to spend the evening with me. Let's get started if I can progress. Okay, so for those of you, if this is your first virtual rounds, welcome. If not, you're a seasoned veteran. Happy to have you back. So we're going to start by going through a quick case, the physical exam. We're going to develop a differential diagnosis together, develop an assessment and plan, and then we're going to talk a bit about bleeding disorders in this case. So as I said before, I won't be calling on anybody, but I will be posing a lot of questions to you guys to kind of get you to think kind of clinically and critically about the case, and start building some of that diagnostic reasoning. So I don't know how many of you know what a SOAP note is. It was not something I knew coming into medical school, so I like to quickly go through that with you guys before we start. So I think first, though, we do the little, here we go. Here's the SOAP note. So I want to just quickly go through this with you guys so no one feels lost. There's a lot of acronyms in medicine, so I like to clarify. So we'll start with subjective. Can somebody tell me what that means? Or what would go in that part of the note? Feel free to unmute or type your answer.
Yeah, subjective is based on like the subject's own experience. So it's whatever the patient reports essentially.
Perfect. That's exactly right. So anything they say. So if they say my pain is a 10 out of 10, it's awful, it started in my shoulder, it's like a horse is sitting on my chest, that would be subjective. And then objective, as on the other hand, is then what? Okay, so objective is going to be something that we get from the patient. So if the patient says, I'll use the abdomen as an example. If they say my abdominal pain is the worst pain of my life, it's awful, it's a 10 out of 10, you have to put that in the subjective part. Patient reports 10 out of 10 pain in the abdomen. But then say you go and press on their abdomen and it's soft and they're not flinching, they're not wincing, then you would say a non-tender abdomen in the objective, because that's what you are using your clinical reasoning to glean from the patient. So that would be the vital signs and the physical exam. Then in also any laboratory imaging, any laboratory studies, any imaging, those would also go in objective. And then as for the assessment and plan, everyone goes about this a little differently. Sometimes people will start with a summary statement about the patient, quick kind of rundown of the problems that the patient is experiencing. Say that would be abdominal pain, anemia, smoking cessation, might be 3 different things in your assessment of the patient. And then we develop plans for each of those. So we'll go through that together. Sorry if this is a little redundant for people. I just like to go through it in case you haven't heard it before. Here we go. All right, so here we have Kason. He is a previously healthy 16-year-old boy who was brought into the emergency department with persistent bleeding from his gums after an elective tooth removal. Oh, you're in Michigan. Hi. I'm actually from the Midwest too. Go Midwesterners. He reports it started immediately after the surgery and is non-painful. Here's Kason posing lovely for his picture. So I'll give you a second to put that in your note if you have it open. And then I usually like to wait for someone to give me a little thumbs up in the chat whenever someone is done, and then we'll move on. I'm happy to circle back to these slides at the end too if you need more time with the note. So I'll wait for someone to send something in the chat and then we will keep going. Anybody good? Awesome, thank you. All right, so somebody start, or anybody, throw out some questions we'd like to ask Kason now that we kind of have him in front of us. We've gone to see him in the emergency department bay. What would you like to know? No question is a bad question. This is a judgment-free zone. You have no idea how many terrible answers I've given in my life. Family history of bleeding disorders is a great one. And I think you're getting at that many of these are hereditary. So that's probably one of the first questions I'd ask as well. So you ask Kason that, he says, actually, yes, I forget who, but a couple people in my family have known bleeding disorders. They bruise a lot, but I'm not sure which ones they have. Great question. So he's coming in with after the tooth surgery, got a bunch of gauze in his mouth, getting a little nervous that the blood hasn't stopped. Anything else you'd like to know about him, about his life, about his habits? Anything that might affect bleeding? One more question. Come on, guys. Okay, we're a little quiet today. That's okay. So here are some questions that I probably would have wanted to ask him. So I might say, when did it start? Was it immediately after the surgery or a little after? And you'll find that that timing is important to kind of start getting to the bottom of what might be causing his bleeding disorder. Since he's coming in after this tooth impaction, another thing I might like to know is, have you had surgeries in the past? Because it might be important to know, is this the first time that it happened and all of the other surgeries he's had were fine? Or is this the first time he's ever had a surgery, in which case this may have presented even earlier had he had more surgeries? That's another good question. So to that one, Kason says, no, I've never had any surgeries like this in the past, or any surgeries at all. Any dietary restrictions or recent changes in diet? Does anyone have any theories as to why maybe I'm asking about medications and dietary changes? This is kind of a challenging question. Okay, so certain like vitamin, yeah, okay, great one, Alex. So diet changes can definitely cause anemia from like lack of iron. So vegetarian and vegan diets, certainly we are concerned about iron. So that's a great one. That can definitely lead to like low blood counts, pallor, bruising, bleeding. Another kind of subtle one that you guys, I don't think I would have known until medical school, would be certain vitamin deficiencies, especially vitamin K, can lead to some of those cells that contribute to clot formation not functioning properly. And we'll talk about some of those later. So also some vitamin deficiencies in addition to the iron. Medications as well can kind of affect your ability to clot. Family history, as was mentioned already, is a great question to ask. I'd like to know if he's bleeding anywhere else. Have you been having a lot of bloody noses? Have you been noticing any bruising, any swelling of the joints? Maybe like if you bumped your knee and then your knee became huge because there was a ton of blood in the knee. That's a condition that we'll talk about later. Recent illnesses, chronic health conditions, things like chronic kidney disease, things like if you were septic, meaning an infection has gone into your bloodstream, those things can also cause difficulties bleeding, or difficulties with clot formation and cause you to bleed. So these are kind of some higher level questions, but I thought it would be nice to kind of see maybe where someone at just a couple steps maybe beyond you would be thinking. So this is, I think, a good place to start. So here is what Kason tells you. This is going to also go in the S part of your note. He does have a history of easy bruising. He says maybe when he's playing sports, he bumps himself and notices that he's bruising a little bit. As I said, he does know that he has a couple people in his family with some histories of easy bruising and joint swelling, but he's not really sure if they've ever been diagnosed with anything specific. He has just had this one procedure, nothing before, not on any medications, and no allergies. I'll give you guys a couple seconds on this one, and we'll keep moving. All right. Like I said before, if you guys need more time on this at the end, I'm happy to circle back to this slide. let's move on to his physical exam. So now we've moved into the objective part of Mr. Green's case. So temperature, pulse, BP, respiratory rate, O2 saturation. Just taking a quick look at these vital signs, do we notice anything abnormal? Do you feel that these are concerning vital signs, or do you feel that he's pretty stable right now? We like to look at them and see, are you stable or are you unstable? So anybody have a gander at if he is stable or unstable, if this is concerning or not?
His pulse is kind of high, I think.
Yes, you're exactly right. So we like to look at 60 and 100 as kind of our bookends of what normal is. So below 60 is considered bradycardia and above 100 is considered tachycardia. So you're exactly right. He's just shy of a high pulse. So I would probably, I wouldn't necessarily flag it, but certainly I'd note it. And this could be because he's a little anxious. This could be because he's dehydrated. This could be because of a couple of things, but absolutely that's something I'd be looking at. His BP is a little low, but this is not concerningly low, especially if he's young, if he's maybe athletic, something like that. Respiratory rate 16 on the nose is pretty average. That's kind of a good respiratory rate. And he's saturating 99% on room air, which I'm also happy with. So we look at his general appearance first. He's a little anxious, but who wouldn't be if they're bleeding out of their mouth? He's alert, but he seems to be appearing well. He's not lethargic. He's not pale, nothing like that. We look at HEENT, which stands for head, eyes, ears, nose, and throat. So we're seeing some moderate post-surgical bleeding and clot formation at the site of his impacted tooth removal. No other gingival bleeding, meaning he's not bleeding anywhere else in the gums. We look at his nose. The nasal mucosa is moist, no traces of blood. As I said before, we want to make sure he's not bleeding from anywhere else, any of the other mucosal sites. Eye and ear exam were also unremarkable. Chest, he had regular rate and rhythm. We're talking about the heart here, meaning his heart isn't beating too terribly fast or too slow. It's not beating irregularly and no murmurs. I think I'm doing another session in a couple of weeks about cardiac structure and function, which is my favorite thing. So if you want to come talk about hearts more in a couple of weeks, I hope to see some of you guys there. Abdomen, soft, non-tender, non-distended. And on the skin, we are seeing some large ecchymoses on the patient's thigh. Does anybody know what ecchymosis means? Anybody have a guess?
Bruising?
Yeah, that's exactly right. Ecchymosis is a fancy name for bruise. So he's got a big bruise on his thigh. He does not remember getting it. He's just as shocked as you are to see it. So this is a little bit of a concerning case, especially in a child since he's 16. So something that would want to be on our radar is potentially abuse, which I'm not trying to make light of. It's something that we need to keep on our differential for any of these children coming in with signs of trauma. So although his case is not suggestive of that, that's something that we would have to note. So I just want to say, as you move forward clinically, any child presenting with traumatic symptoms, we have to consider that on the differential as well. So given all of this that we've seen with Kason, he's got the bleeding, he's got the bruise, family history. Is there anything you'd like to order? Now, this is kind of a tricky question because I know many of you may not have had a lot of exposure in the medical field. I'm not sure. I know I certainly didn't before going to medical school. So this may be a little tricky, but are there any things that you're interested in looking at in him? Any images, any maybe blood studies? Blood test for platelet count. That's a great one. Yes. So we definitely want to draw blood. We would love to look at the platelets. Platelets are one of the main components of kind of the way that our blood starts to clot. So that is a great test that would be included in our CBC, or a comprehensive complete blood count, rather. Sorry, my brain is like turning to mush today. So yes, these are the things I would start with. I would start with the CBC, or complete blood count, which includes white blood cells, red blood cells, platelets, and things like that, including a couple other immune cells, and the coagulation panel, which is it's basically going to test clot your blood and see how some of the different factors involved in clotting are functioning and how well your blood is clotting. So for someone who's having excessive bleeding like him, that would be a nice panel for us to have. So that's what we'd like to order. So what would you put on your differential diagnosis given everything that we've seen with him? I know we haven't had the lab results back yet, but this is a lot of times how it is in the hospital, where you'll get the patient and they're like, the labs are pending, and then you don't get them for a minute. So based on everything we have, what are we thinking right now? No answer is a bad answer. Although you guys have been really spot on, so I'm very happy. We're thinking about his family history of the bleeding. We're thinking about maybe his age. We're thinking about some of the other symptoms we've seen with the bruising, the post-surgical bleeding. What else? No medications, no concerning vital signs. Anything you've heard associated with bleeding disorders in the past? Perhaps.
The only thing I can think of is hemophilia.
That's a good one. Yeah, actually, that's definitely one that I would put high on the list. I was hoping someone would say that, and we are going to talk about that one later. That's kind of that famous bleeding disorder that's hereditary, and we will talk about that. So that's a great one. We'll get into the nitty-gritty of how hemophilia occurs. That would certainly be on the differential. There are also diseases that I wouldn't necessarily have put on the differential had I not just gone through medical school, but there are some disorders of platelets. Someone mentioned looking at the platelets that can be on the differential as well. So I think just looking at the different components of blood, and there are diseases that suggest something wrong with each of those components, we would put those on the list as well. So yes, I'm glad that you got the big hitter one. Yay, the labs came back. So here are a couple things that we're seeing. This platelet count would be on our CBC, and the rest of these three down here are from our coagulation panel. So I don't expect you to know where these are coming from, but I just want you to look at them and tell me which value here is the one that's concerning to me. This is not a trick question.
The partial thromboplastin time.
Correct. So we are concerned about that. That's like double what it should be. So that is actually a very good test for us, because that tells us, that actually points to something specific dysfunctioning in the blood cells. And we'll talk about that in the blood cells, in the blood. So we'll talk about that in a second. This is a very concerning value, and that actually kind of leads us strongly down our road to a diagnosis. So now we've moved into the assessment and plan. This is Kason. I'm going to do a quick summary statement because this is how I was taught to do it. He's a 16-year-old male with a family history of abnormal bleeding who presented to the clinic with excessive bleeding following an elective tooth disimpaction. Subsequent workup demonstrated an elevated PTT, which is that elevated thromboplastin time that we saw a second ago. These findings are highly suggestive of a secondary hemostatic disorder, and we will talk about that. So like I said, the way that I was taught to do it is you kind of number each of the concerns you have. Kason is really only here with one thing, so this one is a little boring, but he's here with postoperative bleeding, likely secondary, that's a 2-2, to hemophilia, as someone said before. You got it. So some of these things I would like to order for him. We can actually look at some of the specific factors involved in clotting, so we can do specific assays for those. So I'm going to order some of these assays to see which type of hemophilia he has, because there are a few. And we can just go ahead and replace those factors that are missing or dysfunctional in him. And so that's why we want to know which of the factors are dysfunctional. We want to continue to control his bleeding, of course, with gauze, make sure his head's not, dipping too low, make sure he's keeping his head up. We want to follow up daily with CBCs. I want to make sure he's not like bleeding anywhere else and rapidly losing blood and I've missed it. So we want to make sure those platelets don't drop, the blood cells don't drop, he's not anemic. And then we want to provide counseling about excessive contact sports. So if this kid is having issues with his tooth bleeding, he had that big bruise on his thigh that we didn't know about, we want to make sure that he's not doing like hockey or something like that, probably. Or if he is, that he's getting educated about it. But I'd probably just go ahead and say probably don't do hockey. So we are now going to move into the teaching portion of the lesson, which I think is going to be a lot of fun. If you're not done with your soap note, that is okay. I will circle back at the end. So we're going to talk about blood. There are 4 main components to blood. Can anyone throw out some of these 4 components for me? Don't have to name all 4. Just anything you can think of that you'd find in the blood. Red blood cells. Yes, that's one of them. Platelets. Absolutely. White blood cells. That's 3. 4th one's a little trickier. Also starts with a P. Plasma. Yeah, Brian. So these are the 4 main components of blood. There is other things in there too. There are proteins, there are antibodies, there are other things also found in the blood, but these are the 4 main components. Now, when it comes to bleeding, we also call these defects of hemostasis. There are 2 main ways that bleeding can occur, and those are disorders of primary hemostasis and disorders of secondary hemostasis. So you'll notice that with Kason, we thought that it was a disorder of secondary hemostasis, and we'll talk about why. So primary hemostasis, we'll talk about each. Here are the basics. Primary hemostasis abnormalities are caused by platelets being dysfunctional, one of those primary components of blood. So this is a great website, non-sponsored, but Osmosis, please sponsor me. This is a great website for learning points in medicine. They have these great little videos and they talk about different things and their graphics are really cute like this, so I like them. So this is how platelet plugs are formed. So this is a vessel. If it gets damaged, say you get bumped or you get like a vaccine or something, these platelets will come before, you'll notice, before the red blood cells are starting to aggregate there on the vessel. So this is the first step. That's why it's called primary hemostasis, in just kind of like going to start plugging the injury before the process of clot formation can occur, because clots take a sec to form. So here are the 2 ways people can acquire a platelet disorder. They can either be inherited or they can be acquired. So you are not expected to know these names. Actually, I think I lied. One of the questions on the quiz, I think, mentions them, but you're not expected to like write them out or anything because they're kind of confusing. So these are all, there are 2 ways the platelets can be dysfunctional. Either they can not work properly or you cannot have enough of them. And some of these diseases are diseases of not enough platelets, and some of these are diseases of dysfunctional platelets. And then acquired. So NSAIDs like aspirin. We also have clopidogrel, which is also called Plavix, which is something maybe you know people who are on who've had like heart caths. There are some other chronic diseases like chronic kidney disease. You'll remember one of the things we asked Kason was, do you have any chronic diseases? So if he said, actually, yeah, I get dialysis and I have chronic kidney disease, that may be a tip that he is having an issue with his platelets. Also, if you're in cardiopulmonary bypass, sometimes those platelets can actually be physically sheared or damaged when they go through all of those tubes. Also, when the blood is stagnant for that long, that can also damage some of the components of blood as well. Any questions about this? I'm like out of breath. I'm just like talking so fast. I will slow down. Now we are going to talk about the presentation of platelet disorders. So how do we know that Kason had a secondary hemostatic disorder and not a primary? So onset. This is going to occur immediately after trauma. I actually think that I'm seeing this now that I messed up the early case. I think I meant to have it occur a couple minutes after the tooth disempaction. I am so sorry. But that's the way that medicine works sometimes. Sometimes people just give you kind of wrong information. So that's what happened today. That's a teaching point. I'm wrong. This is correct though, here on the slide, that these platelet disorders occur immediately after a trauma, meaning if I got cut with something, I would start bleeding excessively right away, versus getting like bumped with something and then over the next few hours, my joint becomes really huge because it just won't stop bleeding into the joint. Symptoms. We'll have bleeding of the mucous membranes. You'll remember that we looked up into Kason's nose to see if his nose was bleeding. We checked his gums to see if they were bleeding. In his case, of course they were, but sometimes people with these disorders will come in and say, yeah, you know what, every time I brush my teeth, I just start like spitting out a bunch of blood. My gums are bleeding a lot. And that could be poor oral hygiene, or it could be something like this. Gastrointestinal bleeding, that will present sometimes with blood in the stool. Cutaneous or subcutaneous. So cutaneous means skin. So we can see these things called petechia, purpura, ecchymosis, you'll remember from before, and easy bruising. So you will notice a little bit of overlap here where some of these platelet disorders and some of the secondary hemostatic disorders will have a little bit of overlap. There will be bruising in both. But what I'm kind of trying to get at is this one is going to be a little bit more like nosebleeds and kind of more like flat, less aggressive bruising, so sorry, versus the secondary hemostatic disorders, which will have kind of more excessive bleeding. And we'll see some of those symptoms in a second. Menorrhagia. This is for women. Your menstrual cycles can be extremely heavy. That can be another tip-off symptom of some of these disorders. And then prolonged excessive bleeding after surgery. We'll see this in both. So like I said, that's why we have to run some of these tests. We have to check the platelets. We have to check some of the coagulation panels to start parsing through which is which, because unfortunately we can't do all of it just based on history, but we can get pretty close. So here's a picture of petechia. It almost looks like a rash, but this will be completely flat to the skin. It's not raised. And it's just kind of little like pinpoint bleeding. So the little teeny tiny ones are called petechia and the slightly larger ones are called purpura, because I remember it because it sounds kind of like purple. Okay, talking about the secondary hemostatic disorders now. These are caused by issues of blood clot formation or degradation. So versus the platelets, this is now the blood cells are starting to get recruited up in there. So this is a very confusing slide that you will have to cram into your brain in medical school should you choose to go down that path, and it will be the bane of your existence. So the goal of all of these pathways is to form this clot down here. We want all of the blood cells to aggregate and stick together with fibrin. But in order to get there, each of these Roman numerals represents a different protein that is going to be converted, and then they're going to stick together, and then they're going to be converted again, and then they're going to eventually help the blood cells to kind of come together and form this stable clot. So there are two different pathways. This one involves here 12, 11, and 9, and 8. And this one here involves 3 and 7. These numbers are not important. It's just kind of a talking point. And then both of them have to go through this 10, 2, and 1 to form this clot. And the reason I'm even getting into this at all is because when we come into some of these hemophilia disorders, like we suspect with Kason, the next step we'd see now that let me backtrack. So remember when we looked at those coagulation panel tests and we saw the thromboplastin time, and you guys noticed that the PTT was way, way, way high. So the reason we're doing that is because the PTT versus the PT, which is that other number that was not out of range, suggests if it's this side the issue or if it's this side the issue. So if it was the PT, meaning his number that was in range, it would be an issue with 7, most likely, or 3. But because his PTT was abnormal, that suggests an issue with either 12, 11, or 9. And so now, because I was able to parse through if it was intrinsic or extrinsic, I can now order a more oh my goodness, what's wrong with me today? I can now order a more focused test, either for just these IS4 or these 2. I hope that makes sense. So that is why we do that test, to kind of start parsing through which is which. And then now we'll order a specific test for him to see which hemophilia he has. Some things that affect both pathways, I mentioned, what is his nutritional status? Does he have any dietary restrictions? So vitamin K is actually involved in the formation of all of these coagulation factors. So if you have a vitamin K deficiency, if you're super malnourished, even some children who aren't breastfed and don't retrieve appropriate nutritional support can develop bleeding because their blood cells are not functioning properly and they're not forming clots. So vitamin K is super important for that reason. Certain medications, you may have heard of this drug warfarin or Coumadin. This one actually antagonizes vitamin K, and so that's actually how the drug works. This drug is used to disencourage clot formation. So that's actually a positive in the case of this drug. Yes, that was all I wanted to say about that. I hope that makes sense. I know that the slide is a little overwhelming, but the main thing I want to stress is that secondary hemostasis is different than primary because one is platelets and one is these clotting factors. And then when we get into secondary hemostasis, we can use tests like the PT and PTT to determine which side is wrong within this pathway. And then from there, we can order even more specific tests. The point of this is to save money and time for the patient, so we're not ordering a million unnecessary tests and also taking a bunch of their blood for no reason. So hemophilia is the one I think maybe a lot of you guys have heard of before. This one was seen in this royal family because there was a lot of like intermarriage within these kind of higher up people. So Queen Victoria is a known carrier of hemophilia. She happened to have hemophilia B, which is X-linked recessive. I'm sure you remember from biology that X-linked recessive means that it is attached to these sex chromosomes. And if a female has just one, then she will be a carrier, like these two little pink guys right here. But if a male receives only one X, then he will fully have the trait, which is why it's more common to see males with these X-linked disorders than women if they are recessive. So that is what happened with Kason, and he is a male, and so he's 16. We might want to tell him, it's you likely have this hereditary disorder. It's likely if you have children, they'll be passed on. Okay, so now back to secondary hemostasis again. So we're going to talk about the symptoms and if they pop up. I did my transition wrong. So this one is delayed minutes to hours. This is what Kason should have had if I was not a dunce and did not put that wrong in the early slide. So this is going to be, the way this is going to look more in the clinic is like, yeah, I was playing a soccer game and I fell over and I bumped my knee and then I went home and I thought it was just hurt, but now my knee is like doubled in size and it's super painful. That's probably because a bunch of blood collected up in the joint and just like expanded the knee. So we call that hemarthrosis when there's blood collected in the knee. These people will also have a lot of bleeding after surgery, which is what Kason had. And you'll see that some of those primary hemostasis people will also have that. But I think of this one as more of like this deep tissue bleeding. So they'll have hematomas as well, which is like a pocket of blood within the body somewhere. So if I got like punched in the stomach for some reason, I may have internal bleeding. Whereas if I had a primary hemostatic disorder and I got punched in the stomach, I might just have like a huge bruise. I may not have like a giant pocket of blood. I don't know if that difference makes sense, but that's kind of how I think about it. I don't know why I keep getting punched in the stomach in this example. Large palpable ecchymoses. So palpable means you can feel it. It's raised on the skin. So versus the other one, This is going to lead to larger collections of blood that will actually kind of become a bit raised. This is a picture of a hemoarthrotic joint here. So you can see that this knee is not correct. It's a little too large. And so how do we start working up these people like Kason? We will start with the history and physical as we did. We'll pay attention to some of these things. So known bleeding disorder in the family is huge. It's just really hard for adopted people because you wouldn't know what their family history is. But if they do know their family history, super, super important. The first thing you learn in medical school is that the history can really lead you probably 80% of the way to most diagnoses, if not even further. We want to know if he's got any chronic illnesses. This is more pertinent for older individuals in general, because typically you're not going to see children with chronic kidney disease and liver disease unless they have some sort of other hereditary condition. But it is important to ask. We want to know if he's been acutely ill recently. If Kason said, actually, yeah, I was just in the hospital last week and I was super sick, I was on a ventilator, that would be important for us to know, because that can kind of change the way your body's production of some of these platelets and clotting factors can occur. Poor nutritional status, as I said, if he said, yeah, I recently went vegan and now I just haven't really eaten very much in the past 6 months, nothing wrong with being vegan, but sometimes when people are on these restrictive diets, they can not be as balanced as they should be if they're not being cognizant of their nutritional intake. So something like that may be important. Don't be mean to vegans about that. Some of them are very, very cognizant of these things. Pregnancy can. So when people are pregnant, we want to make sure that they are sorry, I don't know why my brain is mush today. We want to make sure that they are having proper support. We want to make sure that they are aware of some of these symptoms that can occur. And the use of certain medications. Like I said, if they said, yes, I recently had a heart procedure and now I'm on a blood thinner, that would be important for us to know, because then we don't necessarily have to start hunting for any of these hereditary conditions if they're taking a medication that can cause bleeding. There are even some antibiotics, some common antibiotics that can lead to increased risk of bleeding. So these are things to be cognizant when we're prescribing as well. Diagnostic studies. So this is more than we initially ordered for Kason. Typically with pediatric patients, we order less tests just because I had a pediatrician explain this to me once. We don't want to take as much blood from them, and I don't know, every time I've tried, so I do adult medicine. Every time I've tried to order a lot of tests on a pediatric patient, I get yelled at by the pediatricians. So I think they try to be more conservative with what we're ordering for children. I'm not sure if that is because insurance. I'm not sure if that is because there are less conditions that affect children than adults, but just be warned when you're in the pediatric hospital that pediatricians are super nice, but don't try to order too many tests on their patients. So these are some things that you would consider ordering, although I wouldn't necessarily order them all. CBC, as we mentioned before, the complete blood count. BMP is a basic metabolic panel. This will be for basic electrolytes like calcium and sodium, potassium, etc. So for him, we didn't really need that necessarily because it doesn't seem like anything would be, he didn't really come in with anything suggesting problems with that. And also that doesn't really lead us any closer to our blood bleeding disorder diagnosis. Liver chemistries. So the liver is actually where these proteins are produced, and this is where these clotting factors are produced. So if he had like a cirrhotic liver or liver cancer or something like that, that change the function of his liver, that could affect his ability to bleed just because he doesn't have enough clotting factors. But he is young, he has no history suggesting liver disease, so I wouldn't order that on him. A blood smear is maybe some of those pictures you've seen of the red blood cells on the slides, on the histology slides. Those can be important, so we can actually see on them sometimes aggregates of platelets or no platelets at all, or destroyed red blood cells. So sometimes these are important to see. I wouldn't necessarily order this for Kason either, because I don't really think this is going to lead me any closer to a diagnosis in him. You'll see this a lot in patients who you think may have a malignancy or a cancer, because you can actually see those cancerous cells on the slide. So not necessarily for him, but it would be fair to consider it. Coagulation panel, absolutely. That's that PT-PTT thing that we ordered. Platelet function assay. So this is where you can kind of test the platelets and see how well they are working. So you can kind of throw them in a tube with some other substances. And if they clot together, that means the platelets are working fine. That would be fair to do here. Had his coagulation panel not come back, because the coagulation panel test is what told us that he had a secondary hemostatic disorder versus a first. And von Willebrand factor is one of those, is a factor that interacts with platelets. So again, this would be a primary hemostatic disorder. This is a specific test to see if it is this, this specific protein that is dysfunctional versus the platelets. Okay, back to Kason quickly. So what do we think Kason has? We think he has hemophilia. He's got the excessive bleeding in a healthy young male. He bruises easily. He's got the family history, isolated PTT elevation. Definitely think he's got hemophilia. Remember that this is an X-linked recessive disorder. It almost exclusively affects males, which makes sense because they only have one X chromosome. And I think that brings us to the end of the session. I kind of sped through that because my brain is mush today, and I'm really sorry. So I will open the floor to questions. I will open the floor to going back to other slides, and I will hang out with you guys until the end of the hour if you guys need anything. I'm also here to answer general questions about medical school, about residency, about applications for any of these medical school processes. I'm also one of the editors and advisors. So I'm here for whatever you guys need for the next 15 minutes or so. Thank you guys so much for being here.
Thank you.
Thank you.